All right, it's top of the hour. So thank you all for being here. Welcome to our first Providence, Alaska Project Echo Dementia session, the first of 10. And we're so grateful that you took time out of your day to learn about this really important topic. So I'm just gonna make some introductory remarks and share my screen. And then we will go around with introductions. So hold on here. So some of you may be familiar with what a Project Echo telementoring clinic looks like. But some of you, this may be new. So I'm just going to talk about the model because it's really an important kind of container in which to learn with one another and to gain confidence and knowledge. So as you saw, as you were logging in, we take our continuing medical education very, very seriously. And we have CME credentialing. And also we have some disclosures, which you can see on the screen. I'm not going to read them, but we are making the disclosures and have taken mitigating steps. Okay. So each telementoring clinic, you're going to be asked after to go on to the Seattle Science Center site to complete the survey in order to obtain your CME. And this, we can send this out through the chat as well, and then also at the end of the session. So, and then you'll use, it's a unique code for each session that you'll use. You have up to 30 days to complete this, but we'd like you to do it shortly after the session where it's, you know, closest in your mind, freshest in your mind. And then you'll be eligible for 10 total CME credits. Okay. So those are some reminders. Then we're going to go around and make introductions. I'm going to talk before we do that actually about the ECHO model. And then we'll have the didactic, which Dr. Christopher Rhodes will be presenting today on diseases causing dementia, masquerading conditions, and red flags. Then we'll have our case presentation by Dr. Candice Shlafmann, and then closing notes, the evaluation, and the topic for next session. So, you know, we really try to keep this super germane to your day-to-day. So it's a pertinent and focused evidence-based brief didactic around dementia, and you've seen the topics in the emails. And then there's a case presentation from our community of learners that in Alaska. And then we'll have some opportunity for discussion, questions, reflections, thoughts, summary, and recommendations. So we are all learning together, and so, you know, we have an hour, so we want to try to be concise with our conscious contribution, and we want to speak. I know I'm speaking in the royal we, but I mean I'm talking collectively here. We want to, you know, if I'm talking, I will speak from my perspective and understanding that there are differences around many, you know, training and cultural experience and so forth. And we want to protect all PHI. And all sessions are recorded and available through the Mountain Pacific Quality Health site. And so in the spirit of like the culture of this extending community health outcomes, or the ECHO model developed at UNM, we want to be open and curious and humble, because we can learn from one another. And it really is all teach, all learn. It's a collaborative effort in our community that we're building over these 10 sessions. And please, if you can, we'd love to see your faces. Certainly when you introduce yourself. I know there's sort of Zoom fatigue, so if you want to go off camera after, but when we're going around, we'd love to kind of get a sense of who you are, where you're from, and so forth. Okay, so as we've said, it kind of connects this community of learners, and it's collaborative, and hopefully you come away with improved sense of what to do next in your day-to-day. So all teach, all learn. There's some interactive components. There may be some guided practices and ongoing mentorship, which Chris and I offer throughout the 10 weeks. There's peer-to-peer learning and some collaborative problem solving, creative and collaborative problem solving. So here is just a nice description of who benefits and how. So the traditional telemedicine is you have a specialist who sees a patient remotely. This is really different from our model of ECHO, which is tele-mentoring, and it builds capacity locally. And as you see, we have our community of learners together, and we scale that knowledge when and how folks want and need in their communities. So it provides the right care in the right place at the right time for the patient. By participating in this community of learner, we all learn with one another, and we can treat more patients with confidence and knowledge. And hopefully through this, you'll have a community that you could reach out to in Alaska. It reduces disparities. We know that there's improved sense of kind of impact or engagement through participation in ECHO, which can help with burnout. And then at the system level, there's increased access. We hope that it raises the level of quality and reduces the cost by providing the care locally. So this is sort of repetitive, but just to see in this graphic, there's amplification by leveraging technology with this telemetry clinic. It's case-based learning and sharing of best practices, which help to have a standard across this enterprise or across states to further address health disparities, which, as we all know, are pretty rampant. And then we can monitor these outcomes by using web-based database and some harmonization with other collaborative efforts with ECHO. Okay, so that's pretty the same. Okay, so I'm going to now introduce, before we do that, I'm going to stop my share so that I can see everyone. And please do, if you can, turn on your camera. And so I will model what I would like you to do. We're going to keep it concise. So my name is Nancy Eisenberg. I co-lead Project ECHO. I'm up at Swedish Edmunds, and I'm the medical director for our Center for Healthy Aging. Okay. I'm going to ask Chris we'll introduce you and then we'll introduce you again, but please introduce yourself, Chris.
Happy to. So I'm Chris Rhodes, a neuropsychologist and associate professor in neurology here at the University of Washington. I guess I would say down here in the University of Washington, and co-lead of this as well as our ECHO Washington program with the good Dr. Eisenberg. And again, just thank you all for taking time out today to do this.
Fantastic. Okay, so Amber, I think we can maybe unmute, please.
You'd think after all these years. Amber Rogers with Mountain Pacific Quality Health.
Fantastic. And Kimberly.
Hi, I'm Kim Young, and I'm with the Alzheimer Resource of Alaska.
Great. And Mary.
Hi, I'm Mary Argonis from Mountain Pacific. I'll be your technical support.
Thank you so much. And Ursula.
Hi, I'm Ursula McVeigh. I'm the medical director of hospice and palliative care with Providence, Alaska. Thanks, everybody.
Fantastic. And Lisa.
I'm Lisa Stimson. I am a nurse practitioner on St. Paul Island with SCF.
Oh, terrific. And Gay.
Okay, yeah, Gay Wellman with Alzheimer's Resource Education Specialist out in the Copper Basin area.
Super. And Christopher.
And I'm Chris Piramalli. I'm a palliative care physician at South Central Foundation.
Thank you, Chris. And Shelby.
Hi, I'm Shelby Farthing, and I'm a caregiver connection specialist at the Alzheimer's Resource of Alaska.
Great. And Tracy.
Hi, I'm Tracy. I'm a nurse practitioner on the inpatient palliative care team here at Providence Hospital in Anchorage.
Thank you. And Karen.
Hi, I'm Karen Kelly, and I'm the Executive Director of Homer Senior Citizens.
Super. And Karen Heath.
Good morning. I'm Karen Heath. I'm at the UAA Center for Human Development.
Terrific. And Kelda.
Hi, I'm a program officer with the Alaska Mental Health Trust Authority.
Fantastic. And Nicole Tucker.
Oh. Hi, I'm Nicole Tucker. I'm the physician fellow at Providence, Alaska Medical Center.
Great. And do you want to introduce? Okay, yeah, please.
I'm Candice Shlafmann. I'm one of the hospice physicians in Anchorage.
And our presenter today. Thank you so much. And I know this seems like it's taking a long time, but we do really want to hear from everybody. We're not going to do it every time, but for today, please just bear with us so we can see your beautiful faces, hear where you're coming from, and kind of just greet one another. It's an old tradition to greet one another. Carolyn.
Hi, my name is Caroline Hogan. I'm a health program manager with Senior and Disability Services.
Great, thank you. And Casey Shear.
Hi, I'm Casey Shear. I'm a family nurse practitioner in Soldotna.
Okay, Luann, great.
Good morning, I'm Luann. I'm a case manager at Tanana Chiefs Conference.
Great, and Kathleen Young.
Hi, I'm Kathy Young. I'm a family practice doc, and I also work for WWAMI.
Okay, super. And Sarah Dwayne. Or maybe we'll come back to Brian.
Hi, Brian Schilling,
Hi.
integrated care team pharmacist for Anchorage Native Primary Care Clinics.
Super. And Sarah, thanks. We can see you. Okay, Lori Toure.
Hi, I'm Lori Tara Dewan. I'm a clinical psychologist at Providence Family Medicine.
Oh, thank you. Okay, Lori, thank you.
Hi, I'm Lori Teray. I apologize, I don't have a camera on my laptop. I'm Lori Teray. I'm a Swedish Medical Center CME specialist.
Thank you for being here. And Emma.
Hi, I'm Emma. I am a nurse practitioner at the Swedish Center for Healthy Aging in Edmonds.
Great. Michael Baldwin. Or Mike.
Either works. Mike Baldwin with the Alaska Mental Health Trust Authority.
Great. And Marge Stone King.
Marge Stone King with AARP Alaska.
Super. Okay, Ryan Wallace.
Hi, I'm an addiction psychiatrist with Prov in Anchorage.
Super. And Deb?
Hi, I'm Deb Etheridge. I'm with Southeast Alaska Independent Living.
Great. And Leaf?
Hi, I'm Leif Thompson with TCC. I'm employee health medical supervisor, family medicine by training, and I'm here for selfish purposes because my mother has dementia.
Thank you for being here. And Kristen?
Kristen Cox. I'm a health program manager with Senior and Disability Services.
Great. And Erin?
Hi, I'm Erin. I'm a nurse practitioner fellow at Providence, Alaska Medical Center.
Great. And Tony King.
Hi, Tony King. I am the pharmacy manager for Mountain Pacific Quality Health. I'm in Helena, Montana.
And Aaron. It's moving around a little bit. Okay. Rose, how about Rose? I think you're muted.
I'm Rose. I'm a nurse volunteer for Hospice of Kodiak.
Great. And Catherine?
Hi, I'm Kathy Giesel. I'm a nurse practitioner in Anchorage.
Thank you. And Diane? Diane Nospick? We'll come back to you. How about Helena?
I'm Helena Jagelski, Director of Nursing at Seward Mountain Haven.
Great, thank you. And Christina Cohen?
I am a clinical pharmacist at Valley Native Primary Care for South Central Foundation.
Super. And Holly? Blake? Okay. Aaron? Carter?
Hi, I'm sorry. I thought I went already, but maybe I didn't.
Maybe you did. I'm sorry. They're moving around. Connie, sorry, I thought you did, and then you moved around. Okay. Microphone not working. No worries. Stephanie Johnson.
Hey, good morning. My name is Stephanie Johnson. I work for South Central Foundation as a community resource specialist.
Great. Helen Boggs.
Hi, I'm Helen Boggs. I'm a director of nursing at Petersburg Medical Center.
Great. And Elizabeth Kohler.
Hi, Elizabeth Kohler with Norton Sound Health Corporation. I'm the audit nurse.
And Ann Lewis.
Hi, I'm Ann Lewis, a registered nurse here in Anchorage.
Great. And Janice?
I'm a neurohospitalist at Fairbanks Memorial Hospital.
Great. And if anybody else, if I'm missing, please just unmute yourself and take yourself off camera and jump right in.
Hi, Katie Baldwin Johnson. I'm with the Mental Health Trust Authority.
Great.
Hello, Kylie Viens. I'm a dietitian with South Central Foundation in Anchorage.
Anybody
Sarah
else?
Nelson, Sarah Nelson, community health aid practitioner and CHAP specialist for SCF.
Super. Thank you. And if you can't, right, get yourself unmuted, just feel free to introduce yourself in the chat. Thank you. All right. Well, so I think that I am going to introduce Dr. Christopher Rhodes. So we're super fortunate to have him, both on, there we go, both as the co-lead for this ECHO and also UW Project ECHO, which is in Washington. And today he's going to talk with us about diseases causing dementia, masquerading conditions, and red flags. And as he said, he's an associate professor in neurology at University of Washington. So take it away. I'll stop my screen share.
Awesome, thank you so much. Again, if nothing else, keeping track of the 50 people who are on here and getting introductions done in less than 15 minutes is an achievement. So thank you for that. And boy, as I bring up my slides here, what an amazing group of people in terms of expertise and location and background. Can you see slides there? Is that? Nancy, is that?
Yeah, we can. It looks great. Can I just also pause, because I wanted us to do one thing right before we do this to dive in. Sorry, which I, again, in my adrenaline. So I want you guys, I don't want you to press play yet, but I want you, or just press send in the chat. But I'd like you all to think about, this is a 10-week Project ECHO Dementia community. What are 2 things that you'd like to take away or come away with after the 10 weeks are completed? And just first, like, compose them in the chat, and then I'm going to say send in just about a minute and a half, and we'll look at okay, send.
Cool.
Okay, go.
Yeah,
Sorry.
I look forward to seeing what populates there. Okay, so my pleasure to kick this off this morning, or I guess this afternoon. Reviewing kind of the main causes, things that in the primary and specialty care setting that we need to be aware of. My hope is that by the end of this, 17 minutes or so, you'll have a better understanding, we'll have a better understanding of the sensory medical psychiatric conditions that may either mimic, masquerade as, or raise risk for cognitive impairment and dementia. To talk about how to assess these objectively, both in busy primary care and other specialty care settings, and then talk about the most common, the big 4, maybe 5 most common forms of dementia, knowing that each one of those is like, many slide, many hour talk in and of itself. But we're gonna kind of hit the highlights here with some resources for where to go from there. The other thing, I have no disclosures. So just big kind of big picture ballpark stats here for 2021 from the Alzheimer's Association. Incredibly common problem, right? 6.2 million Americans, 5 million with MCI, half of which are due to AD, or Alzheimer's disease. So importantly, half are not, with many million of those maybe due to treatable or modifiable things. And then if we think about our 45-year-old plus population, where I am firmly ensconced, there are 15 million with subjective cognitive impairment, which may be a harbinger or precursor for MCI and dementia. We know general risk is still about 10% after age 65, escalating as we age. And that segment of the population is the most rapidly expanding, as you can see here in purple, the 85 plus group. And equally importantly, and kind of somewhat staggeringly, less than half have a diagnosis. And of those who do have a diagnosis, less than half are told about that diagnosis. And even fewer providers have standard protocols either in their practices or organizations for how to detect, diagnose, and manage dementia. So a lot of work to do. And these numbers really obscure some critically important differences and disparities. So women, we know, are disproportionately affected by dementia, in that 2/3 of all people living with dementia are women, and moreover, 2/3 of all caregivers for people living with dementia are women. And there are likely multiple reasons for this, including some biological, but maybe even more importantly, educational, occupational, and social determinants of health that shape that. And similarly, compared to Caucasian counterparts, our older African-American and Black adults, 2 to 1 in terms of dementia risk and prevalence, 1.5 to 1 for older Latinx, Hispanic, who tend to be diagnosed at a later stage and with more severe symptoms. And we do not have great data around American Indian, Alaska Native populations, although some of the work that we're doing and coming out of Kaiser would say that this is probably close to 2 to 1, with, again, that very, very important awareness around ethnic class and the idea that there are probably more differences and often more differences between, say, tribes than tribes and other ethnic groups. And certainly, I mean, thinking about Alaska Natives versus Plains or Southwest or Northeast tribes, huge differences in culture and risk. So really being attuned to what a nuanced disease and set of diseases this is, and how it interplays with a variety of factors more than just biology. If we drill down into Alaska, we've got about 12.5 thousand cases, with a significant increase by 2025, close to 30% increase. It is your 9th leading cause of death in Alaska, although the 3rd lowest mortality rate. DC and Maryland are the 2 lowest. It looks like, if I'm reading the stats right, the increase in deaths for those with dementia has increased about 16% during the time of COVID, which is about what it is nationally and here in Washington as well. And then huge care and costs estimates here. And interestingly, Alaska has the highest rate of increase in anticipated Medicaid costs in the next few years. Not quite head and shoulders compared to other states, but well above even the next state in terms of increase. So a growing and significant problem. And for any of you who do clinical work there, I don't have to tell you that. So just again, background, if we shift gears to the classic question of what's normal, what's not, in terms of cognitive function and thinking abilities as we age, we know things start to change in our 4th, 5th decades with notable changes around 65 in things like processing speed, complex attention, aspects of short-term memory, not so much procedural memory, long-term memory, verbal fluency, those kinds of things. There's another set of changes that occurs around age 85. These, again, are healthy, normal changes. One of the benefits of objective cognitive assessment is it helps disentangle that and clarify it. But we know for millions of others, there is a different process unfolding, which is this gradual accumulation of neuropathology. So amyloid beta and tau, if we're talking about Alzheimer's disease, potentially alpha-synuclein, if we're talking about Lewy body, which is, again, this gradual, slow-burning process that causes a different trajectory for cognitive functioning, with a couple of distinct stages and phases. So important to realize that there is a silent or asymptomatic prodromal phase where the disease is present, but no symptoms are evident. Should disease burden increase and either function or structure of the brain change and cognition changes, you may have mild symptoms with no functional impairment. Should that, again, continue to progress, you now enter the territory of dementia with maybe early, mid-late, and late stages. So this really is a continuum. And for someone in your practice or for whom you're encountering that you're concerned about this, there are some things that we should be thinking about immediately, ruling out and assessing for. First and foremost is sensory change. So hearing and vision loss. If you're going to have somebody remember a list of words or draw a cube, you want to be sure that sensory things aren't contributing to any impairments there. We have amplification devices and over-the-counter readers available for those who forget theirs or maybe haven't been prescribed. Pocket Talker is a great resource. Certainly metabolic conditions, B12, thyroid deficits, the classic dementia labs, Careful eye towards medication side effects and polypharmacy, especially in our older adults who may be compromised or vulnerable in other ways. We see a lot of folks here who are on things like Benadryl or Tylenol PM or Unisom for sleep with significant anticholinergic effects, or the bladder medications, certainly narcotics, opiates, benzos and benzo derivatives for sleep. And really wonderful resource if you're not familiar with it, the Beers criteria to look at relative burden for anticholinergic effects. Ruling out delirium, which is a more rapid and acute process, typically associated with underlying infection, urinary tract infection, could also be organ failure or electrolyte disturbance or medication side effects. We also see a tremendous amount of older adults with undiagnosed and untreated sleep disorders, and some great scales to help assess or screen for that. So Stop Bang is a great one for obstructive sleep apnea. I also like the Epworth scale, which will get at some other sleep disorders like REM behavior disorder or periodic limb movement. These are easy to administer and score in multiple settings. Again, always making sure you're screening for alcohol, marijuana, other drugs. I like to save those questions until the end of the visit. You might have some rapport established and maybe a little bit more transparency and honesty about that. The audit is a good tool for that. Depression and anxiety, a number of tools there, PHQ-2 or the 9, geriatric specific measures like the GDS-15 or the geriatric depression scale, or the geriatric anxiety inventory. And then of course, other rarer medical conditions like normal pressure hydrocephalus or seizure disorder. So these are all things that should be in the back of our minds or the front of our minds as we encounter older adults who are concerned about changes in memory, and making sure we're screening for these, assessing and ruling them out, or treating them if possible present. I'm including this just as a resource, and these slides will come to you at the end of this. We'll make sure that all the links are clickable, so easily accessible for all the tools that I just mentioned. But really some key differences between dementia, delirium, and depression. And as we move on in this series, there are some nice ways to assess that with objective cognitive screening like the MoCA that help disentangle some of these things. So important construct of mild cognitive impairment, this kind of gray area between normal aging and frank dementia. And again, this rubric on the side here comes from Ron Peterson's most recent work around the ways that we think about MCI. But important to note that not all MCI, so again, this would be, I've got cognitive impairments, but I'm functioning pretty well. Not all MCI progresses to dementia. About 10% of people with amnestic MCI progress per year. That number might be closer to 18% if it's multiple domain, like memory and executive functioning. And it may be a precursor of some other neurodegenerative or cognitive process, but about 10% of people with MCI revert back to normal aging. And these are the people with the conditions that we just talked about once those are detected and treated. And these, kind of here on the right side, biomarker presence is important, not always known or achievable, but it will become more important as we think about whether that opens the door for early intervention with a disease-modifying agent, and certainly once a plasma test is available to be able to assess these things outside of a tertiary setting. Moving down the continuum of cognitive impairment, we get to the territory of dementia, which again is not a disease in and of itself, but an umbrella term encompassing different diseases that cause dementia or give rise to dementia, the most common of which being Alzheimer's disease. This also is for your reference. We could spend hours on this in terms of how often these things occur, what are the first symptoms, how does that map onto the architecture of the brain that's changing, and the pathology that is driving that change, and the associated genetic factors. If you are deeply interested, we have excellent didactics for each of these as part of our Washington Echo that are available on our website. Happy to send you links to those. But wanted to give you a sense of, what are the most common things that we tend to see, Alzheimer's disease being the primary. What does it look like? It's kind of gradual, insidious onset with a fairly stable course relative to something like dementia with Lewy bodies, where there are fluctuations and hallucinations and Parkinsonian symptoms that help distinguish it. So again, just kind of skimming the surface on the big four here that you're most likely to encounter. And just also making sure that we're thinking about this as a lifespan disease, that this is something that is occurring well before we see clinical symptoms. So we know that changes in amyloid beta and tau are occurring 10, 15, maybe 20 years before clinical symptoms are evident. And the importance of that early detection. Again, biomarkers will help that, but they're not as widely available as we would like yet. And that this is really a slowly progressing, for most folks, a slowly progressing disease, where it could be a 30-year course of 10 years or 15 years of pre-symptomatic stage, followed by 10 years of MCI. And then once you've crossed the threshold into dementia, from diagnosis to death can be from 2 to 20 years, depending on comorbidities, age of diagnosis, stage of diagnosis, but still with about 10 to 12 years being average across the mild, mid, and late stages. And I would say the most common form of dementia is mixed dementia. And I think historically, especially in academic medical centers like ours, we've done disservice by trying to say it's either this or this, when pathology confirmed diagnoses would say it is the rule, not the exception. So 100% of late onset cases with at least 3 pathologies. This comes from our colleagues at UCSF and mirrors the pathology work that we're doing here at the Alzheimer's Disease Research Center. For those with late stage Alzheimer's or late onset Alzheimer's, cerebral amyloid angiopathy is the most common co-occurring disease, followed by Lewy body. And then for late, again, after the age of 65 onset, vascular comorbidities are extraordinarily high. The degree to which they're contributing, or maybe even primary, really hard to quantify sometimes, but really just being attuned that it's rarely one thing or the other. What should we be thinking about in terms of when it's time to consult with a specialist or other colleagues? I would maintain that a huge proportion of individuals with dementia either both can be and should be diagnosed and treated in primary care settings when appropriate and the providers have the right training. Not everybody needs a neuropsychological evaluation. Not everybody needs more advanced diagnostics. But when you've got somebody with early onset, so somebody in their 40s or 50s, you might be thinking about FTD or maybe early onset AD. Atypical onset, of course, so something rapidly progressive, unusual neurological symptoms, any of the neuropsychiatric symptoms that might lead you down the pathway of Lewy body disease, or maybe FTD, where both diagnosis and treatment are going to be trickier. These are certainly some of the things that would prompt a referral to a specialist. And then, as I mentioned, I want to make sure you have links and resources, both the references and the actual measures themselves for all the things that we talked about. So these are all the links that are active as of yesterday. And we'll make sure these are all clickable. So if you're interested in integrating some of these into your clinical practice, either at maybe a Medicare annual wellness visit, or when you or somebody else has concerns about cognitive change, how to bring in the objective measures. I'm going to thank you. This is my contact information. And I'm going to put this picture up here to remind myself and tell you that I'm not in the ivory tower of the University of Washington. I'm in the brick tower of Harborview. And we've had a bunch of helicopters in and out all morning. So hopefully nobody from Alaska. But yeah, so there you go. And I'm going to stop sharing with that.
Fantastic. So fantastic, Chris. What a great talk that covered at a high level so much, and so many tools that will be helpful. We do have a couple of minutes for questions, so I would invite our community. If you have a question, you can do it in a couple different ways. You can unmute yourself and just ask it. If you prefer to put it in the chat, we can monitor the chat as well. Any questions?
The only other thing I would say is the other very cool thing about this model is that both Dr. Eisenberg and I are available in between the sessions too. So if you have a question about something tomorrow or next week, do not hesitate to reach out. That's part of the value of participating in this. Maybe I've successfully bludgeoned people with information.
I'm gonna just.
I guess I would ask, do any of you already have experience with these tools, or what have you found helpful? What did I miss? What did I leave out that you've found super helpful in your practice?
Anybody encountered situations with Tylenol PM or those types of medications that can cloud thinking? Has anybody had an experience with that, or other medications that they'd like to share?
This is Chris Piramalli. I was just going to say something recently with an elder was hydroxyzine, which is this very benign medication, sometimes used as a way not to for anxiety or other reasons. But I've seen several elders have pretty profound effects, and then as soon as it was stopped, resolved the cognitive impairments. And so that was just something I wanted to share.
Thank you for sharing. We really appreciate that. And so important to take a really careful appraisal of all the potential contributing factors, including medications, polypharmacy, many, atarax, hydroxyzine.
There's a great question in the chat from Michael Baldwin asking, the line between normal aging and MCI, and boy, it's somewhat arbitrary, right? However, it's usually defined as a standard deviation and a half from either someone's peer-based normative group or their own kind of level of function. So if you have objective cognitive testing, that helps with that. If you don't, which not everybody does, it's that territory of, boy, I'm having trouble. It's not just the every once in a while forgetting a word or going into a room, forgetting what you went in there for. It's the persistent occurrence of that, and I'm having to implement more safeguards and strategies, and I'm having trouble with my driving, so I'm using my GPS a lot more, or I'm having trouble tracking my medications. So I've shifted to a Mediset, and that's helping. That's kind of that line of like, I'm still functioning pretty well, but I and others around me have noticed this, like, boy, there's something more than average here. Or if you do something like a MoCA, there are some ranges that will be assessed or associated with MCI versus dementia. And we'll talk about that more in a future session.
Dr. Rhodes, there's also a question in chat about it's hard to find a specialist available in Alaska with specialized dementia diagnosis and management. Can you talk a little bit about how to get more assistance in that realm in Alaska?
Excellent question. It's common here as well in terms of the rural parts of our state, or systems that don't have a lot of resources for specialists, and people end up traveling tremendous amounts of distance. But in terms of who can help, I mean, certainly the specialists that I think of, and I'm not not just physicians, but other providers with training and expertise in geriatric psychiatry or psychiatry in general, neurology, geriatrics, and the opening up of the telemedicine, to do a new patient evaluation around cognition is a little different than something with a more complex, like a movement disorder or other neurological condition. So hopefully this opens the door a little bit, but yeah, it's incredibly hard. And it's incredibly frustrating sometimes when you get a referral to a specialist and it's not a specialist in that. So you get a specialist to a neurologist, but it's not a neurologist who works with dementia.
And I'll just add, if I may, and I absolutely agree with everything that was said, and it is very hard, and it's not just a state problem, it's a national problem and really a global problem. And on the flip side, and this is really important for our work over the next 10 weeks, you know, there are too few specialists, too few geriatricians, too few cognitive neurologists, too few geriatric psychiatrists. And what our intention is for this project, which was funded by an innovation grant and is under a larger umbrella of age-friendly care, which I'm not going to talk about right now because it's sort of off topic, but the purpose of this is to really build this capacity. And we know, and I'm very confident, and this has been borne out in experience, that you all know your patients best. You have a relationship with your patients over time. You know their care partners. And so you all can provide excellent, comprehensive dementia care for most patients who have late onset mixed dementia. And then, as Chris said earlier, you know, we are a resource to you. We are available between sessions. You can email us. And then the person who presents, this is another incentive for presenting perhaps, the person who does the case presentation will additionally receive a written recommendation from Chris and me, which has our emails and our cell phones and so on. So we really are, we want you to know we're here, we're available as a resource. And we also are committed to building the confidence and the knowledge within this community of learners. And I mean, I think that the talk that you just gave is just representative of that effort as well, because it was just terrific. So shifting gears, if I may, unless there's not another pressing question, I think we got to keep moving. So I am also super excited to, and thank you again in advance, Candice, for giving the first of the case presentation. So Dr. Candice Shlafmann, I hope I'm pronouncing your name right, is going to present the first case, and she is part of Providence, Alaska Hospice and Palliative Medicine. And what I'll do is I will just kind of show the case as you're presenting, if that's all right with you. Okay.
Perfect. I didn't know how detailed you wanted this, so I'm just going to talk, and if you want more details, please let me know. But this is a 77-year-old African-American woman with a complex past medical history, including likely vascular dementia with a history of cerebral vascular accident, COPD with chronic hypoxemic respiratory failure on 2 to 3 liters of oxygen, chronic pain with a history of substance abuse, and chronic lymphedema that impacts ambulation, who was recently hospitalized for 2 weeks. She was brought into the ER at that time following a fall and found to have a slow GI bleed with anemia, status post-transfusion, acute liver injury concerning for autoimmune process, and encephalopathy. Further workup was declined and the patient came home to hospice. She currently resides in a 2-bedroom apartment with her daughter and son-in-law. She is largely bed or chair bound. Daughter has been assisting with transfers, though some days the patient is able to do this independently. She's been having increased agitation, which is described as argumentative and yelling that occurs nightly between midnight and 1 a.m. She's also noted to have hallucinations of her family members as well as animals and shadowed figures. She is wandering the house at night, which daughter knows from the video monitors around the house. Family states that seeing her deceased family members is a gift and is reassuring to the patient, but the animals and shadowed people are distressing. Her daughter's been managing her delirium with non-pharmacologic management, such as redirection and reassurance. The daughter is now not sleeping at night and becoming increasingly fatigued. She is the primary caregiver for the mother and has no relief. She wants her mother comfortable but prefers not to be sedated during the day. Her physical exam is notable for the patient sitting independently on the side of the bed with oxygen in place. If she slides forward, her daughter has to physically move her back on the bed. In general, she has no jaundice or scleral icterus. She has clear lungs. Of note, her lower extremities are edematous bilaterally, but are non-pitting. Cognitively, she's able to provide some history. She's able to hold a discussion. She does cry out in pain, but appears comfortable and is easily distracted by a change in subject. She does see a snake attacking the sheet of her bed during the exam. Medication-wise, she's been pared down for hospice and is currently on duloxetine 60 milligrams, gabapentin 100 milligrams nightly, and Tylenol and naproxen as needed for pain, usually once a day. She does take Senna 8.6 milligrams daily as needed, simethicone as needed, and pantoprazole as needed. And then prognostically, she appears to have weeks to months to live.
Great. And so what a terrific way to start us off with a concise presentation with a lot of information and a very complex, challenging situation in a lot of ways. So what you were asking us was how can we manage this sundowning that's happening at night? How can we advise around sleep-wake reversal? But before we go to those questions, which I think are really important, I wanted to maybe for a moment stop the share, excuse me, and come back into our community to see if anybody had any questions or clarifying, any comments or questions for Candice about the case. Or observations. Yes, please.
This is Gay Wellman. Yeah, I'm just curious, how much support is the daughter getting as far as education and things like that? Has she reached out to any agency like Alzheimer's Resource?
I think she had education in and around dementia, but other than that, she really didn't have any other resources. We gave her a rundown of what to expect when we were there on our visit.
So that's a great question. What is her level of understanding about what's going on? And at the same time, what I heard you say was she doesn't have, it sounds like, any practical assistance in the home. Is that right?
Right. She has a husband who is there but isn't really helping. All of her brothers and sisters are no longer talking to their mother, so they haven't been helping her at all. So she has no other support and is not accepting of PCAs at that time.
And then I just see in the chat, what about adult day services and respite care and an assisted living?
So I don't think the daughter had the resources to be able to provide adult day services. And then unfortunately, Alaska is a unique beast. Our hospitals are currently full from COVID and we don't have anywhere else to house our patients for respite care. So that is unfortunately not an option at the time.
So these are great questions and they're really pointing towards some of the, holes in our care system. And please, somebody.
Yeah, this Gay, I'm sorry, would she be open to talking with someone at our agency for support?
I'm sorry, who is your agency?
Alzheimer's Resource of Alaska. I'm sorry.
I honestly don't know. Sorry, the end of the story is the patient is now deceased.
Oh, okay. Okay.
And I only got to meet her once.
So this is wonderful, Candice. Thank you. And I think that we're just learning about resources in the community. We're learning about how people can present. And does anybody have any thoughts about the neuropsych? Any other questions or comments before I start to ask some more pointed questions, maybe?
I have a question. I wonder if, just to follow up on Gay's question, can you speak more about what Alzheimer's Association, what support you do provide patients and families, just for us to know kind of locally how we can look at this from many directions to help?
I would suggest you ask Kim, since she's on your panel.
Thank you.
Kim, would you like to share? That'd be wonderful.
Okay, sure. So we provide consultations for caregivers that can be via phone or in person. We do have that, we have to be wearing masks and things like that, but we do meet with caregivers. We also provide consultations for people living with dementia on the phone or in person. We have classes that are now on Zoom. We're not doing any classes in person, so we have a variety of different topics. Our education specialists are presenting, or else we'll have someone from the community who has expertise in a different area will come and present, like on Medicaid or Medicare or something like that. And if anyone's interested, you can just get a hold of us at the Alzheimer's Resource of Alaska and just call our main number in Anchorage, or I'm in the Wasilla office, and we can help you we can add your name to the email list so you can get information about what the classes are up and coming and things like that. So we offer classes. We also offer support groups for people for caregivers, and we offer general support groups, and we have several different programs. We have BrainWorks and Mind Matters, and those are for people living with dementia and their caregivers, support group for both. And so we're doing everything online right now. Let's see, did I miss anything, Gay? Have I?
I like to talk about the art links
yes.
program,
Art
the
links.
specialized programs. Yeah, because
Yes.
it's really cool.
Also,
Yes, we have-
Kim, the Caregiver Connection Program.
Okay, so we have Art Links. We have two different programs for connection for people living with dementia, and one is called Art Links, and this is connecting through art, and my wonderful colleague Janice facilitates this one, and it's for anyone living with dementia, or just, you know, anyone who's isolated, at risk for social isolation, loneliness, things like that. And it's an hour, it's twice a month. And again, you know, contact our agency to get on our email list if you know anyone who would be interested in this. And the other class is the Memory Cafe, and that's engaging through music. And my colleague in Anchorage, Ann Ferris, facilitates that program, and it's wonderful. She has musicians from across the state come in and play, you know, and she herself is very musically inclined, so she always has a great program. And so it's a wonderful way to get people connected, people living with dementia, people who are just lonely and just, you know, looking for some interaction. So we have those, and then, yeah, go ahead, Gay.
I think it's the professional webinars.
Oh yeah, and we have the professional webinars as well. And these are also, we have this wonderful, we have a quarterly newsletter that we can send to you, and you can register for classes right on there, and everything that I'm talking about is listed on that. So, you know, if you're interested, just let us know. But the professional webinars are, you can get CME credits, or hours rather, for taking, you know, our professional classes, and those are wonderful as well. So we offer those. Anything else, Gay?
I'm putting the website in the chat box.
Oh, excellent. Okay, there you go. Well, good.
As you can tell, we're very proud of our agency. It's a wonderful place to work.
Absolutely.
Yes, it is.
I'm just curious, can people, how many of you were familiar with these incredible resources that you have in Alaska? Just seems like some wonderful programs.
Yeah, and I might add, even being familiar with it, there's always more you don't know about what an agency like this is doing. And Kim, can I also help clarify, even though the name is Alzheimer's Resource, I hear you speaking to dementia support in general. Can you speak just briefly about kind of who's eligible for the support of the Alzheimer's Association in Alaska? I mean, meaning that it's not just the diagnosis of dementia, of Alzheimer's. Is that correct?
Oh, no, it's not just yeah, our name says Alzheimer's, but it's for anybody who's having cognitive issues, whether it be, you know, from a TBI or from, yeah, anyone who's having cognitive issues. It's not just Alzheimer's, it's the other progressive dementias. It's just anyone can come to us for help.
Terrific.
And this is Chris. I'm seeing something about grants in the chat. Do you guys offer grants as well?
Oh yeah, we also offer grants through the Alaska Mental Health Trust Authority for people living with dementia. They're up to $2,500 per fiscal year. And these are for items that can help support quality of life, safety, you know, and more fun things to do, like, you know, if they wanted to more activity-based type items, clothing, bedding, just a lot of different items. And so we help that way too. And so call us if you know anyone who's, you know, might be needing this grant or might be interested, or have them call us, reach out to us.
Thank you.
I'd also like to add, we currently have a pilot project going on at Alzheimer's Resource in Anchorage specifically. There's a little bit more details to it, as in the person living with dementia cannot be on Medicaid waiver. and they must be in their home, not in assisted living. But if anyone knows a caregiver who could use some support and very limited funding, definitely encourage them to reach out to our office.
Oh, and we also have mind aerobics. That's our new program we have through the New England Cognitive Center, which is a research program, and it's for anyone. We have two programs. One is MindWorks for people living with early, just got diagnosed, or for people living with dementia. And so we have Mind Sharpener for people who are just in that worried about their memory. And these are classes that are, we have exercises in the classes that help to exercise different cognitive areas, like, language, memory, and it's just, they're really great. They're, we offer, let me see, they're twice a week for 24 sessions, and there's a cost for them, but we also have scholarships that can help if someone can't pay, so we don't turn away anyone. And they're really great because not only are you exercising your brain in these classes, but you're connecting with other people throughout the state in these wonderful classes. And I think we just started this program this summer in July, and we have taught, I think, 4 classes so far. And again, go to our website, you'll see everything's on our website. Our website has really recently been redone, and we have all of these things we're talking about are on there. It looks wonderful. So
this is so fantastic. What a great resource. I want to return for a moment in the last couple of minutes to Candice, and just the questions that you asked. I want to see if anybody in the community has ideas about how to manage the sundowning or potential medications that, just so I understand that this person is no longer with us. And at the same time, if anybody, maybe a pharmacist, had some thoughts they'd like to share in a concise minute or so, just since that was a question you posed. Or anyone, or any thoughts about the sleep-wake reversal? No right answers.
The comments that some, Shelby said that I've heard some success for caregivers using a happy light for sundowning, and then exercise and keeping a pattern to the sleep-wake cycle is also in the comments.
Great. So the circadian clock doesn't work as well with neurodegenerative disease. So maybe using a happy light in the morning, or getting people out and moving, although she had limitations certainly, but those are great thoughts. Any other thoughts people have?
So I know the community doesn't have much at the moment, but what are your clinical recommendations? Because I know we have like 4 patients on our service right now that do these like 24 to 48 cycles up, then 24 to 48 cycles down, or hours down. And just looking at a pharmacological intervention in patients we've already tried non-pharmacologic management who may have a couple weeks of life, and kind of where you guys would start.
Well, I mean, I would be concerned about, if you're asking me, I'll take a stab at this. I'm a little concerned about the Cymbalta, because that can really cloud people's thinking as anticholinergic. So I probably would have I understand it's being used for pain on the one hand, and on the other hand, I would be concerned about that. In terms of these cycles, it's really hard without doing a very careful behavioral analysis. But if she's combative and irritable, sometimes a low dose of an SSRI or even Depakote. She was not on a cholinesterase inhibitor or memantine that I'm recalling. Is that right?
No, she wasn't.
Yeah, I mean, sometimes memantine can help with neuropsychiatric symptoms as well. Those are sort of 3, understanding that largely, it's usually behavior modification, education for the care partner, sometimes changes in environment, you know, those types of things. In terms of medication, unfortunately, with, you know, advanced dementia, there's no silver bullet is really what I would say. And I welcome any other concise thoughts on that. I wish we had better treatments. All right, so.
Quick more note, the CME, you actually go to the swedish.org /CME for the website. I put that in the chat. And remember, you do have to complete an evaluation to get your CME. So make sure you have time to register.
Yeah, yes, thank you. And then we're going to talk at the next session. I want to be super thoughtful about y'all's time. Next session is on the 24th. We're meeting every 2 weeks for 10 sessions. I'm going to be talking about putting dementia prevention into practice. So dementia prevention, really focusing on these modifiable risk factors. And then we have a case presentation by Emma Dodson. And please email or reach out to info@mountainpacificqualityhealth.org or amber@mountainpacificqualityhealth.org if you want to bring your case forward. And thank you all and have a great rest of your day.